Should I start? A very warm welcome to all of you, and thank you for joining us today on the occasion of the World Population Day for the webinar, which is titled Advancing Women's Sexual and Reproductive Health and Rights, a Step Towards Universal Health Coverage. This webinar is hosted by the Lancet Citizens Commission on Reimagining India's Health Systems and the Population Foundation of India. I'm Poonam Mutreja, and I'm Executive Director for the Population Foundation of India and co-chair of the Citizens Engagement Workstream of the Lancet Commission. Citizens Commission. In the past few decades, India has made significant progress, as we all know, on several health and fertility indicators, as is evident from the data from the Fifth Family National Family Health Survey and FHS 5, which was done between 2019 and 21. And was released by the Ministry of Health and Family Welfare, Government of India. And some of the key notable highlights there were that India's total fertility rate, which is TFR, the average number of children that would be born to a woman over her lifetime, now stands at 2.0. This is below the replacement level of TFR of 2.1. At which a population exactly replaces itself from one generation to the next. So there has been a significant increase in the current use of any modern contraceptive methods, which stands today at 56%. So the quality of care in family planning has significantly improved, with 62% of current users reporting having received information on side effects from service providers, which is greatly increased from 46% in the last survey. But yet there are areas of concern which remain. Anemia and obesity are growing causes of concern amongst young women and adolescents and children. 57% of all women at reproductive age are indeed anemic still, and almost a fourth of the adolescent girls continue to get married before the age of 18. A third of ever married women aged between 18 to 49 years have experienced spousal violence. So while the increase in the use of modern contraceptive methods is indeed heartening, an increase in female sterilization coupled with continued stagnation in male sterilization uptake shows that the onus of family planning continues to lie on the shoulders of women, while the use of condoms has gone up by 10%. Its uptake continues to be low. In other words, there is a limited male engagement in family planning. Men are missing. We need to bring them in. At the heart of the universal health coverage is a commitment to equity so that all individuals can access the health services they need. So we will require advancing strategies to address interstate and interregional variations in the health indicators, and addressing social norms impacting health behavior, investing in the unmet reproductive health needs of adolescents and young people, need strengthening within the public health system. So to discuss these and related issues, I welcome you to the webinar today. During the discussion, we not only hope to highlight the progress that has been made, but we also hope to discuss areas of family planning, gender equality, maternal health, and reproductive rights. But also we would like to underscore future strategies needed to achieve the unfinished agenda. The business of universal and equitable access to health services in line with India's commitment to the SDGs. I now request Dr. Niranjan Sagurti, Country Director, Population Council, to share a presentation on India's sexual and reproductive health services. Niranjan is a public researcher with more than 2 decades of experience in SR, HR and population issues. Niranjan and the Population Council have been analyzing NFHS data and population issues. So Niranjan they've been doing this through multiple lenses. Population Council's analysis has been extremely useful and appreciated by all of us, including the government. So Niranjan, over to you for your presentation. Thank you for being here.
Yeah, thank you so much, Poonam. Also, thanks to PFI and the webinar organizers for giving us the opportunity to present the situation on sexual and reproductive health in India. So let me share my slides, which is going to be a quick presentation because I would like to hear more from the panelists on their thoughts around what needs to be done going forward. On this very day, we are all committing to the adolescents and young people, and also the kind of issues that you have raised in the introduction context setting. So let me share my slide deck. I hope everyone is able to see the slides.
Yes, Niranjan.
Yeah. So let me just. Yeah. Thanks once again. So what I'm going to briefly talk about is a context in which where do we stand in terms of the sexual and reproductive health in India, and why we need to focus more energy on the adolescents and young people, and also what are the emerging areas if we need to achieve the universal health coverage. For example, what is that we need to do, and what's the way forward in terms of what lessons have we learned in the past 10 years and how we can continue to take those lessons forward. And this is a context slide which speaks by itself, where you can see the district level adolescent population when we map the major part of our country. About 579 districts in India have over 15% adolescent. And why is it important? Because there is a huge population size that's entering into the reproductive age. And as we go on continuing to work on the sexual and reproductive health rights, we need to also take the cognizance of this population size that we have as a country, which is also a great demographic dividend at the moment, given the potential that it has for both economic growth and the development. And I will also talk a little bit about, what's the difference between the service provision versus choice and rights. From my perspective, we have done really well on the service provision when it comes to the family planning, maternal health services. Government has done, and also the development partners have actually contributed a lot to addressing or making sure that there is an access to the services. But is that the access to services is sufficient enough from choice and rights perspective? And the third is more on the universal coverage in terms of what is that we need to focus. So if we look at this graph, which talks itself, when we have the TFR of 4 or above, the maternal mortality rate used to be over 400. When the TFR was 3.0 and above, the maternal mortality was 300 plus. And when it came down to 2, and as we reach the replacement level of fertility, the maternal mortality rate also has gone down significantly. So there is a significant relationship that exists between how much the working on making sure that the fertility issues are addressed for women also saves the lives during the childbirth. There is a huge area to note on how the gains on working in the area of sexual and reproductive health can actually help also reduce the maternal mortality and achieve the sustainable development goal. On the other hand, as Poonam said, we have reached the replacement level fertility. And when we look at that from urban and rural perspective, both in terms of the modern contraceptive prevalence rate and also the total fertility rate, the large, as you can see from here, there is this reduced gap in terms of the MCPR. The rural and urban gap in MCPR has reduced from 12% in 1992-93 to 3% points in 2019-21, which actually speaks itself that the kind of the progress that we made in the family planning program in reducing this rural-urban gap on modern contraceptive prevalence. At the same time, even the total fertility rate, as it has been gradual decline, rightly so, both in urban areas and rural areas, and urban total fertility rate is way below than the total replacement level fertility, which we need to take into consideration, because it's not just the addressing sexual reproductive health issues not necessarily mean we need to make the TFR below 2.1, but to actually achieve that population stabilization, and which means we need to take note of where the geographies where there is a very low fertility and what is that, what factors are leading to such low fertility. The other program, what program has done very well during the FP 2020 era, as this high focus states and Mission Parivar Vikas program has reduced the gap that exists in terms of the contraceptive acceptance rate between those geographies with low modern contraceptive prevalence rate historically versus the geographies with high modern contraceptive prevalence rates. For example, states in southern India had a high modern contraceptive prevalence rate from early 2000s, but states in northern and the eastern part of India, the modern contraceptive prevalence rate was lower in some other states, not all states. But what we saw during the FP 2020 era is that the reduction in that gap in terms of these high focus states versus the low focus states. And that's congratulations to the program in terms of how they have planned what is that, what really worked during the Mission Parivar Vikas program. On the other hand, if we see, have we done enough in terms of the modern contraceptive prevalence rate? Not necessarily. As you can see from this graph, in both urban and rural areas, there is a huge gap between what the current modern contraceptive prevalence rate, although it is about 56%, 55% in rural areas and 58% in urban areas. It's not enough because there is a total demand of 76% or 78%, which actually suggests that there is also the use of traditional methods is significant, that is reaching to taking the contraceptive prevalence rate to 66%. And we need to take into consideration that why is it still huge 20% points gap between the total demand versus the modern contraceptive prevalence rate? And then the gap that exists between the modern contraceptive prevalence rate and overall contraceptive use, which is explained by the traditional method use. And as you can see, the CPR is on a steep increase in both urban and rural areas from 2015-16 to 2019-21, which is explained by the steep rise in the traditional method use. And I'll come to that point later. But if we translate that into the numbers, as you can see, there's a huge number of currently married women in the age group of 15 to 49 years who has the demand for contraception. But the modern contraceptive methods are able to meet only to about 135 million. Whereas the total demand is about 190 million women. So there is a gap still to address, about 60 million. And when we talk about the universal coverage, we need to make sure that every woman has the choice and the access to the contraception that she needs. And on the other hand, when we look at the traditional method, and this is an interesting analysis that was done by the UPTSU colleagues in Uttar Pradesh, who had shown that how this contraceptive use journey is happening for the traditional method users. If you look at on the left side, the currently married 15 to 29 years, for the adolescents and the young women, the contraceptive use journey, as you can see from this graph, is quite fluid. They're moving between the traditional method to modern contraceptive to non-use of contraception, and then going back again and having the unwanted pregnancies, and then moving to the modern contraception. So there is a huge lot of fluidity that is happening. While there are decisions that are being made, but what the evidence is showing from the right-hand side graph, which says that once the woman start using the traditional method, she will continue to use the traditional method after reaching certain age, for example, 30 to 49 years. But in the meantime, what's happening is for those women, the unwanted, unintended pregnancies are greater than to the women who were using modern contraception. So that is a point to keep in consideration going forward in terms of providing universal access to contraception. So let me briefly talk about, and having seen the kind of contraceptive use journey that exists for adolescent and young people, let me talk about what's happening in the adolescent and young people and what is the situation of sexual and reproductive health. As you can see from this slide, there is this unmarried adolescents who are about 2.1% adolescents, unmarried adolescents. Girls have reported ever having sex, but then the modern contraceptive prevalence rate is quite low. And even for married adolescents, the contraceptive prevalence is low. And the median age at first sex is about 17 years for girls, whereas for boys, it is about 19 years. And even young married, for example, if you look at for 20 to 29 age group, the modern contraceptive prevalence rate among those is 42%. So what this is suggesting that while we work our family planning program and the sexual reproductive health initiatives are working largely for the married woman, there is also a significant proportion of the unmarried adolescents and unmarried youth who require these services. And why is it? Is because there is a whole lot of changes that is happening at each age of this adolescent and the young people's lives. And this is the data from Udaya study that was conducted by Population Council, which actually saw how the transition of the adolescents to the adulthood that is taking place. For example, at the age of 15 years, the adolescent dropping out of the school, some those who are dropping, some getting married, and those married giving birth within a year, and some experiencing pregnancy loss. And similarly, at the age, for example, the 19 years, they're having birth within that, experience a significant proportion experiencing the pregnancy loss. And by the time they reach 21 years, if they were married as adolescent, they are experiencing multiple pregnancies, as well as there is that shift that is taking place from pregnancy loss to the child loss. So, and more women, as they face these reproductive health risks, they're also experiencing the gender-based violence and the sexual abuse, and and unmet need continues to be high in those among those adolescent and young people. There is this transition, and at each age there is a critical event that is taking place, which is defining the adolescent's transition to adulthood. And have we done enough in the sexual reproductive health program to address the needs of the adolescents and young people? That's the question that we must ask ourselves. And then on the other hand, while the National Family Health Survey data has shown a significant reduction in the child marriage, but if we go look at in the overall, but if we look at by district, as we can see from this map, that still over 44% of the districts reported greater than 20% women marrying before age 18. And total of 43 districts identified to have reported greater than 40% women marrying before age 18 years. As the case that we did in the case of the Mission Parivar Vikas program, where the districts and were identified for a focused family planning program. If we need to make a significant sexual and reproductive health progress among adolescent and young people, we also need to design the program that addresses the contextual vulnerabilities that adolescents are facing in those 43 districts or many other districts where the child marriage is continuously high. And on the other hand, even the teenage pregnancies over time, although at overall all India level, it has reduced from 8% to 6%. But when we look at by district, there is a significant raise. For example, in the NFHS 5 data has suggested that 38 districts in India has over 15% teenage pregnancies taking place, and additional 80 districts have over 10% teenage pregnancies. While we talk about the greater success at all India level from 8% to 6% reduction, there is a significant variation that exists by district in terms of the progress that it has made and the continued vulnerability that it has. And on the other hand, the same data suggests that the child health outcomes by mothers age at birth. As you can see from this, one key takeaway that when mother's age at birth is less than 20 years, there is a high neonatal mortality, infant mortality among the children who are born to mothers, who are born to adolescent mothers versus born to the mothers age 20 plus. While that is the case, we can also see from this data that as the children's mortality risk at the neonatal not only remains different for the two different groups, but also as the children grow older, the child mortality is higher for those children who are born to the adolescent mothers versus others. Yeah, here that difference even further expands, which means that the children who are born to adolescent mothers not just experiencing the greater risk of mortality at the very early age, but also are experiencing the issues with the child's growth, nutrition, and other issues of the development. As a result, the child mortality is increasing. So what is all and how is it affecting all this adolescent and young people? And where the evidence from Udaya's study had clearly shown that the early marriage, prevalence of dowry, early entry into motherhood, and high anemia is actually influencing the adolescents and young people's sexual health risks. And the persistent gaps exist in our programming and policy, that there is a low investment in girls' education, and there are high dropout rates and high anemia and other nutrition issues. There are social norms continues to exist, at least in many districts in the northern India, in terms of their related to proving fertility. And there is a provider bias in terms of how much the frontline workers and other health workers and community development professionals are able to speak to the adolescents and young people about the sexual and reproductive health issues, and also the other empowerment and the professional guidance that the adolescents can receive. So besides those vulnerabilities that adolescent and young people are facing, there is a huge potential that we have. However, we need to address a few core issues, and that could be the program or policy focus going forward. One of the issue is the private sector role. As we saw from the data, which clearly shows that over time, the private sector has contributed significantly to the increase in the modern contraceptive rate in urban areas. For example, it has moved from only the 6% MCPR to the 17% MCPR in the case of the urban areas by the private sector. That's the contribution that it had. In rural areas, it has moved from 5 to 19%. So the lesson learned is that there is a huge potential for the private sector to play an important role to address the sexual and reproductive health issues in the country. At the same time, why private sector is critical and why am I emphasizing the private sector role in family planning is because it's the preference of the adolescents and young people. As we see from the data by the age categorization in this slide, which clearly shows the potential of the private sector and how private sector can play an important role in addressing their contraceptive needs. As you can see in the case of, say, the NFHS4 and even NFHS5, we looked at the data, but not included in this slide. What it had shown was that the adolescents and young people are accessing the contraception more from the private sector than from the public sector. So while public sector is continue to play an important role in addressing the contraceptive needs for older the women in the women above age 25 years and women in higher parity, the lower parity is still the preference is for the private sector. And the condoms and many other areas that Poonam spoke about is increasing, and that's where the potential exists. Because we also saw during the FP 2020 era, the reversible contraceptive method use has increased. And as the reversible contraceptive method use increased, there is also this concept of contraceptive use fluidity, which suggests that there is a huge shift back and forth between the methods. While shifting is not a challenge, the problem is about the discontinuation of the contraceptive method use. Before they decide to shift to another method, there is a period of discontinuation. Before, even in some instances, the woman who discontinues a certain contraceptive method use continue to remain in that state or practice the traditional method or do not use any contraception for some time, which is a cause of concern, and that needs to be addressed. And that's where the role of private sector is going to be an important factor. The other is the missing men, which Poonam spoke about. The men's attitude and perceptions about family planning are unfavorable. The data from both the National Family Health Survey 4th round and also the 5th round has clearly pointed out that how the attitudes and perceptions about family planning are unfavorable when we take the considerations on the different situations in which the men were asked questions. Then also there is no change in the overall proportion of male methods of contraception for over 25 years. And vasectomy acceptance is almost nil. As we saw the increase in the condom use over time, but it was compensated by the proportionate decline in the vasectomy proportion, which suggests that whatever the change that we saw in the overall male methods of contraception is very marginal and not significant enough. And prevalence of vasectomy on the method use is only 0.3% in the population, which is way below the national health policy goal. And this data in this slide clearly shows how this trend in total sterilization and what's the percentage share of vasectomy. The burden on sterilization still is with women. The male sterilization has gone down, and the numbers from the Health Management Information System, HMIS data, clearly shows that hardly there are few districts or few geographies where vasectomy, specifically the no-scalpel vasectomy, is practiced. So, and this, if it continues, it's going to, in the next 2 to 3 years, there will be no vasectomy, even if, say, man or the couple decides that man should go for contraceptive use. So, and this is in contrast to what the situation is in contrast to what government's commitment in its national health policy. For example, government's national health policy says that it will take positive steps towards achieving the objective of at least 10% of sterilization being male sterilization. It has indicated, but we don't yet see the progress. And there is a continuous and constant effort to revive the no-scalpel vasectomy and other initiatives for increased male participation, so that men are seen and visible and participating in the family planning program. On the other hand, as the COVID epidemic came into the world, we also saw how migrants were vulnerable on many dimensions. While Population Council, we've been doing a lot of this work on migration and family planning. One of the key learnings that we had, and this was the data from NFHS 4, we did this analysis 3 years back when we saw that the family planning, the modern contraceptive prevalence rate, not only is lower among the women who have migrant husbands, but it is even lower among the non-migrants living in high out-migration areas. So, which suggested that it's not a migration of the migrant is not a challenge, but what is happening in case of the family planning and sexual and reproductive health in the migration areas is that the migration environment itself is making people vulnerable, living in those areas vulnerable for sexual and reproductive health. So in the high out migration areas, both migrants and the non-migrants are actually having the lower use of modern contraception, which raises many questions. What is the,
just interrupt you.
Sorry.
How many more slides?
One slide. That's it. One slide.
Oh, great. Great.
Yeah, sorry.
Lovely.
Sorry about that.
Lovely.
So which raises many questions that what are we doing in those geographies and how do we need to address? And this is my last slide, which talks about the way forward. there are a lot of learnings of how things have changed in the context of family planning program and SRH in India in the past 10 years, and how the expanding choice for more methods, for example, the implants, rings, and introduction, and including the NSV revival, can perhaps make the program more successful going forward. An integrated programming vision for adolescent SRH is the need of the hour. That needs to be given priority going forward, without which we fail, we are likely to fail on the successes that we made and not sustain those successes. And then improved quality of service and care and enabling private sector access given the choice of young people, because we want to ultimately make sure that young people have the choice and the right to the access to sexual and reproductive health. Thank you so much.
Thank you, Niranjan, for such a comprehensive presentation, and you make it so interesting. And I'm glad you brought in the private sector, the issue of migrants, and of course, the focus on young people. And thanks for ending with some suggestions, which are going to be a great segue to our next bit of the program, which is a panel discussion. In the meantime, may I request all the participants to continue putting your questions in the chat box, which will be answered, some even during the panel discussion, and many will take up after the panel discussion is over for the Q&A. So moving on to the next session, we will discuss different perspectives on prioritizing women's sexual and reproductive health and rights as a step towards universal health coverage. We have with us a great panel. We have Andrea Wojnar is the resident a representative for United Nations Population Fund, which is UNFPA India, and the country director for Bhutan. With an experience of more than 3.5 decades, Andrea has been in the forefront of programs that have focused on the rights and health of women and girls, and on giving voice to youth and adolescents. We read a brilliant article by her this morning on what we need to do for young girls. And Andrea has a passion which is greatly combined with her experience across the world. Andrea UNFPA is making news today, and everyone is going to be talking on World Population Day about the new data that has come out. So there is a big buzz you have created. And then we have with us Dr. Priya Nanda, who's a senior program officer with BMGF India, where she leads the measurement and evaluation for social norms and equity. With almost 2 decades of experience, Priya's expertise includes not only research, measurement, and evaluation, but she is a very strong advocate and knowledge bearer of on women's issues, women's economic empowerment, and access to health services, including reproductive and sexual health services. Unfortunately, Dr. Rajni Patel, Dr. Rajni Ved, Director Health of the India office of BMGF, could not join us due to unforeseen circumstances. So let me start with you, Andrea. Given the current health landscape, how do we make sexual and reproductive health and rights a reality within a universal health coverage context in India?
Okay, thank you so much, and good evening, everyone. First, let me congratulate the Population Foundation of India and the Lancet Citizens Commission for highlighting this topic to mark the World Population Day 2022. I think it's a big splash, and with all of us together, we are helping to raise awareness about the real issues. It's true, I was at an event this morning at the Population Institute, and a reporter came to me and he really talked about the doom and gloom of the 8 billion in November that we will reach. And I said, and you'll see it on the news tonight, I suspect, it's not doom and gloom. That is an urban myth. This milestone is a moment for celebration. It's a moment for celebration in the world, and it's a moment for celebration in India. Because across the globe, poverty's been reduced, and we've had incredible advancements in healthcare. We've seen infant and maternal mortality decline, and people are living longer and healthier lives. So that's all the good news. But India has been a global leader in contributing to that success, and the world continues to look to India as a global leader. And what I keep getting reminded by my colleagues is, with regard to the 2030 Sustainable Development Goals, if India succeeds, the world succeeds. If India fails, the world fails. So big responsibility on the shoulders of India, but also big opportunities. So with the youth bulge, it's actually a very, very positive scenario. And sometimes we have to explain this to the public. And I think this is the great opportunity today on World Population Day. So also please let me congratulate the India's frontline health workers, the ASHAs, who did such commendable work during the COVID pandemic. I want to congratulate the Ministry of Health and Family Welfare and the government. I know they're not here today, but I think it's really important. So a couple points. Niranjan said a lot, and he said a lot of the points that I would have said as well, but I'm going to try to sift through and just add on to the things that he said that will complement. First of all, we need a life course focus. Yes, we don't want to focus just on married adult couples. And I see lots of comments in the chat box that young people lie about their ages when they go for reproductive health services. They lie about their marital status. So I think that tells us something, that we need to look at that cohort before marriage and younger people. And of course, Niranjan made that point. So we definitely do want to focus on young girls and adolescents, but also we can't keep ignoring older persons and the sexual and reproductive health of older people. They too have sexual lives, and they too have sexual and reproductive health needs. We won't focus so much on that today, but frankly, the clock is ticking. We won't be able to ignore it for too much longer. As Niranjan pointed out in a general way, girls and women are at the very core of any developing country's progress. And in fact, in India, 1 in 10 persons is a young girl. And so that's 120 million girls. That's enormous. And that's also 120 million opportunities, if we look at it in a very positive way. But I'd like to underline 3 problems that those 120 million girls face from a sexual and reproductive health and rights perspective. First, as Niranjan pointed out, girls are being married off before 18 years. And I know we have the debate in the country about the age of marriage, and we will stick firmly with 18 as the recommended age of marriage because of all the evidence we have seen. Raising that age will not change anything for these girls. As we've seen, nearly 1/3 of all girls in developing countries are marrying before 18 and bearing children within the first year. And then we saw with the data that Niranjan spoke about, it's only after that first or second child that they're actually looking at family planning and contraception, which means we have a spacing issue, which means we have probably a choice issue, and which means that those girls are putting themselves at risk. by giving birth at such an early age. And we know that the risk of an adolescent girl dying in childbirth is twice that of a woman in her 20s. So to me, that's absolutely shocking. And why we allow that is beyond me. We also know, and Niranjan pointed out in the data, that only 17% of married girls are able to take decisions about their own sexual and reproductive health by themselves or even jointly with a partner. That's less than 1 in 5, which is really kind of terrifying when you think about it. They have no say over their bodily autonomy. They are literally an asset for the husband or the families. And that's, as I said, it's really rather terrifying. So how can we look at this in a different way? And how can we convince policymakers? I'm going to try to skip quickly to solutions. We know there are immense benefits for girls delaying the age of marriage. And economically speaking, there's a huge cost benefit to having them marry later. The return is actually 16.8 times ratio. So for every rupee invested, the return is 16.8, which means that India could save $5 billion, the equivalent of 33.5 crore, which is huge in health-related, healthcare and related costs if it eliminates child marriage and early childbirth. For perspective, this is the equivalent of India's 2018 higher education budget. So for me, again, most of us, if we can, we put our pennies in banks or rupees in banks and try to get in a return on investment. Almost nobody gets 16.8 back on their investment. So for me, this is a pretty good one. And I don't know why we would walk away from that. We also know from a major health and social science study by the University of Sussex in India that children of women who marry later are more likely to complete their required vaccinations, have higher weight for height children, and are more likely to enroll at school and attain better grades. Sorry, I meant vaccinations for their children. So again, these are all knockoff effects, but they're further returns on education investments. And this is why it hasn't been said yet in the presentation thus far, but really this is not a health problem. This is a multi-sectoral problem. It's health, it's education, it's law, it's social mores. And therefore the solution is going to have to be about all these areas. So how do we get out of motherhood in childhood? I like that expression. It's used by Natalia Kanem, our executive director. This is where we need to convince government that we need to be investing much more heavily in the adolescent girl to expand her opportunities, to expand the resources and skill sets that will help her avoid early and unintended pregnancies. We also need to change the attitudes of the parents, the grandparents, the aunties, the uncles, and everybody surrounding the adolescent girl. Because until they see her as a valuable asset for education, for income earning, for being a leader in the community and in the family, nothing will ever change. And this to me is one of the biggest challenges I've seen since arriving in India. It's really that iceberg. And we're at the tip of the iceberg. We're hacking away and we're empowering girls, but we really need to focus on the larger community underneath the surface. And that's a much bigger undertaking, but it's certainly one that we have to address going forward. I think we'll talk a little bit about men's engagement. I'll jump to that a little bit later if you allow me. meeting unmet needs of the younger generation. Again, Niranjan talked about service provision. We tend to put a lot of focus on service provision and a lot less on choice and rights. So again, this attitudinal change, I don't think we need to convince the young people about modern contraception. I think we're seeing it in the data. They're going for it and they're finding it in the private sector, where they don't have to lie, where they don't have to be at the brunt of negative perceptions and stigmas and attitudes. So where do we need to go with this? I think it's pretty obvious that this young generation is so techno savvy that if we don't get on with their game, we're going to miss the train. And Poonam, you're doing great work with your chatbot, and there are other initiatives as well, but I think so much more can be expanded. Whether we're talking about
we need to do a lot more, and I hope you will talk in the next round about what all we can do. But I want to say, Andrea, you've just arrived, and there is a lot that needs to be done, and I can see that UNFPA is getting geared to do a lot more. So we look forward to hearing in the next round what you are thinking of doing and the experience you bring from other countries, including, you said you'll address male engagement later. I very much look forward to hearing more about that. But let me go to Priya now. And Priya, so hi Priya. So what are the factors outside of the health system that need to be emphasized in addressing the barriers women and adolescent girls face in accessing family planning, sexual reproductive health information and services? And you have worked on, in the last decade on issues much beyond only sexual and reproductive health. So we would benefit greatly from hearing from you. Thank you, Priya.
Thanks, Poonam, and thanks, Niranjan, for always a stellar, comprehensive presentation, and Andrea for your op-ed and your comments evening. I think a lot of the points have been covered, but it's good that we are focusing on points outside the health system for now, for this round, Poonam, because I think the points that have been, a lot of our health policies are based on the edifice of a life course approach, and really on not only really looking at prevention, promotion, and treatment, but also social determinants. The problem is really the connectedness between the health system and other systems and other sectors, and I think and the operational aspects of it. But clearly, if delaying age of marriage and delaying first birth and pregnancy, because there's so much of the health and economic loss that women are facing is because of teenage pregnancies. We see 40% of women's teenage pregnancies may result in an episode of neonatal mortality. With that high mortality and loss that girls may be facing in their health and other economic potential, clearly we have to work within schools and within systems that are going to help delay age of marriage and advance girls' economic and human capital so that they can be able to be equal, gender equal in economic opportunities, especially in the workplace. We also know that women's labor force participation is very low. The problem is much of the interventions that have been developed to incentivize with higher school attainment actually also are facing the same problems as the health system, which is the fact that there are gender unequal norms that girls face, the disadvantage that they carry with them into schools and in communities, and that works in tandem. So I think that no intervention like a conditional cash transfer program or school uniforms or menstrual pads, none of these can be developed and designed without strong communication approaches that are going to work to really address some of the gender unequal norms that disadvantaged girls and women. So this is really squarely falling in your space, Poonam. But we really, really do need to enhance better, design better, more complex, more multi-layered interventions that really start addressing. And we really need to go outside the box. I think things that you're beginning to do or have done, but many more players need to do that. Second, I think that addressing gender inequity, freedom for women, more autonomy for girls and women, freedom from violence, coercion, all of that work, whether it's safe cities, safe roads, safe workplaces, safe schools, all of that is really important. And that all will work in tandem to really improve women's full and equal participation in the economy. I think we also want to talk about, because the foundation works a lot on financial inclusion and increasingly on digital health, increased financial inclusion for women, which we see with evidence also works towards increased decision-making status, as well as increased digital literacy and digital inclusion. Both of these are actually working to reinforce girls' and women's participation fully, whether it's decision-making within the households or outside. So I think those are really important. I do think the foundation, as you know, is really working towards making all our work and investments, whether it's health sector or outside, more gender intentional. For me, that's really important because it also means in making leadership within the health system and outside the health system more gender intentional. We need more women leadership in the health system and outside the health system, so that we can really ensure that actually women are having equal space in policy making, in service provision, in product and technology development, and all of that should work towards really shifting the gender norms, because I think the visible aspect of that also becomes very important. The more you see the visible participation of women, and I think that does go down the line. I would also like to emphasize this is not necessarily outside the health system, but it was missed in a way. So I want to emphasize that in case we don't get to it, but really promoting a self-care agenda in SRH for women and girls. What does that mean? That means more better products, better design products, but the products that have to work with strong information and counseling, higher provider sensitivity and bias. I think one of the several chat also mentioned that is the public sector more biased against inclusion of adolescent girls, or is the private sector more supportive? Actually, neither. The private sector is not necessarily providing higher quality care. It is just that it is a convenient place to seek care, which you cannot without stigma and bias within the public sector. So I think we have to work to improve quality, bias-free, gender equitable care, and really promote self-care, whether it's in self-testing of pregnancy, HIV, or, as we are developing more, including more contraception and injectables in the long run. All of that has to work together. And I think whether it's a new technology, a new product, the message and the branding of that should constantly be emphasizing that we as a society really believe in promoting more gender equality. I think that message has to go whether it's in the health system or outside. I'll stop here, Poonam, because I know you may have a second round in which some of my other friends would come.
Thank you. So absolutely, we're going to have a second round, and the theme of investing in not only young girls but in women continues. The data tells us that. That's what we heard from Andrea, and we're hearing from you. And and why not? In fact, when I was listening to you, Andrea, I was rephrasing what you said. You said your colleagues tell you that the world will succeed in achieving SDGs if India succeeds. And I was sitting here thinking, if Indian women succeed, because it is on women's shoulder that the entire burden of not just family planning, but dealing with all the other issues you and Priya had mentioned, and the data shows, there's evidence from what Niranjan shared with us. So it's very natural that everything Priya said, also you invest in women, gender equality, changing gender norms, gender intentional. I like the word gender intentional, and I hope you'll speak more to that in the next round. But let me come back to you, Andrea, on the whole issue, given that the burden is so much on women. What do we do about male involvement? How do we take the next steps? Clearly, as we heard from the data, there's been more decline in male involvement than anything else. So, in spite of contraceptive use of condoms increasing, but we cannot only give credit to that to the men. And it's not just about contraceptive use. What else how do we want our men to participate, take responsibility? Andrea.
Okay, thank you so much, Poonam. I'd like to say one of the ways we reduce the burden on women is actually by putting more of the burden on men and by putting more of the burden on the system itself. I think the first thing that needs to happen is to realign the focus of engagement. So family planning programs have traditionally in India and across the world focused primarily on women, and that needs to change. That needs to change. So the public health system finds it much easier to engage with women than with men, and on very few methods within family planning. We've seen that, isn't it? But it all comes back also to incentives. What are we incentivizing in the public health system? And that is something that really deserves a rethink and can change. All behaviors can be motivated with carrots if the right ones are found. So to me, that would be the very first recommendation. Frontline health workers need to be trained and sensitized on providing information and counseling to all young people, and they need to be trained and sensitized to work with men and boys, really to build a cadre of frontline workers to effectively engage more with men and boys on these particular issues. Come up with champions, come up with heroes, come up with promoters, come up with influencers, if we speak about social media, to really shift the dial in a different direction. Strengthen engagement with men and boys across existing programs, and I'll probably massacre the name, but Sas Bahu Samalans, which is part of the mission Parivar Vikas, to include men and target male partners through Nahi Pehal initiative, and ensure again that those ASHA workers are accompanied by male RKSK workers and peer educators. So we can build on existing structures to build in that male approach, including males, but also others talking to males. Greater convergence with the National Service Scheme to leverage the existing network of youth leaders. Because again, we're talking about a whole shift in who we're marketing to and who we're appealing to. So to promote access to SRH and family planning focused information and services. CSOs are doing some good work to promote male engagement, and I think we can do more to share those best practices. We know that 2 out of 5 men think it's a woman's responsibility to avoid getting pregnant. And the acceptance of male contraception is largely built on myths and misconceptions surrounding condom use and vasectomy. So how do we change these myths? We need to get influencers involved. We need to get leaders involved. We need to get those who are willing to stand up and really help move the dial, as I said. But we also need to change the basket of options. Right now, the basket of contraceptive choices in India includes basically 2 male-specific methods, condoms and male sterilization. And Niranjan, you showed the really dreadful statistics around male sterilization and how popular that is. 12% are using condoms and getting sterilized out of 7 methods available. So we have something to work with. We can expand on that. Adapting the messaging around male involvement. It really has to be a multi-sectoral message. It really has to be linked to things that appeal to people beyond just the act of family planning and contraception. We have to link it to economic well-being. We have to link it to overall health of women and mothers and young adolescents. We have to link it to equality and gender equality and the role that that plays in sustainable, what's the word I'm looking for? Not profitable, but sustainable, developed societies that can continue to support themselves in a peaceful and developmental way. And we know it's all linked to gender equality. You cannot find a wealthy, sustainable country in the world that does not have good gender equality. So how do we change those minds?
Yeah. Thank you. You've almost given a program and a strategy to the government because in the vision document that the government is working on, the Ministry of Health and Family Welfare for family planning, male equality, which your UNFPA contributed greatly to when we did the chapter which PFI led. You have a program for them, so they should be very happy, and I hope somebody's taking that. Thank you so much, Andrea. And it comes down to gender equality, of course, as you summed up. Let me come to you, Niranjan, for a quick question on, Mission Parivar was mentioned by you, and it was just the Saas Bahu Sammelan was mentioned by Andrea. Stay there and also talk to us about how the Saas Bahu Sammelan has contributed and what are the other contributing factors to the success of Mission Parivar.
No, we don't actually have the data or evidence on what specific element of the Mission Parivar Vikas may have contributed. From my perspective, I think it's that intensified and focused programming combined with the introduction of new methods of contraception, more so that push in the Mission Parivar Vikas districts has contributed. What it has done, the introduction of new methods of contraception, is that it has initiated those conversations. It has brought together the health workers, given the new energy to the health workers to speak to the couples who are not using contraception, to say that there are these new contraceptive methods and that there is a whole campaign towards it, and talking about these new methods of contraception, which actually has been the trigger from my perspective, besides the other elements of the Mission Parivar Vikas program, which includes the Saas Bahu Sammelan, Nai Pahel Kit, and many other initiatives, because the government, as they have prioritized these districts under the Mission Parivar Vikas, even the district administration and the whole health workforce has joined hands to work in a specific direction. And the new methods introduction has given the torch to go around, talk about it. And that's what we saw in the statistics of the HMIS. If you look at the numbers, for all these new methods that have been introduced, has been a significant progress. And so we saw the reversible modern contraceptive use increase. Then not so much on the sterilization, the female sterilization was on the other hand declining in terms of the numbers, but the reversible contraceptive method use has increased and reflected in the population-based survey as well. And that's a great thing.
Great. And I hope that given the success and everyone recognizing the success of Mission Parivar, perhaps the ministry will agree to evaluate the program and see what are the lessons we've learned and what to build on. So I'm going to come to the last question, and the last question is to Priya. Priya, before we lose you to your call, very quickly, maybe, if you can stay with us for 2 minutes at least, 2 minutes and answer a question. And the question is, what kind of targeted investments in adolescents girls can lead to positive changes in outcomes around family planning, sexual and reproductive health, and helping the transition into adulthood and help the country also achieve the SDGs.
So thanks
And
for
then
that question.
Then we'll go to questions from the audience, which, yeah.
Yeah, just before I go to that, I just want to also say that what we are kind of trying to do a 360-degree assessment of MPV in UP and Bihar, and Peace Pop Council is one of our partners. So hopefully we'll have some data. I won't call it an evaluation. So we will have something, but it is really a lot of it is, and also pointing to that. I know when you introduce the new methods between NFHS 4 and 5, we actually introduced 2 new methods in the public sector. It really helped vitalize and re-energize the family planning program. So I think that introduction of new methods does have that contribution, which I think MPV, you see that in MPV. Even though the coverage of these interventions is still very low, but whatever is happening, it is contributing to expanded use, increase in acceptance. So, there's something positive happening there. We'll know more later. In terms of adolescents, Poonam, I mean, it would literally be saying the same stuff that we've all been saying. Well, I think what's really important to note is to date, we don't have the longitudinal evidence that will say that if we start investing in very young adolescents today, we'll see the returns in family planning use and SRHR. So at some level, it's the right thing to do. But it's not necessarily that we can say that X% investment in very young adolescents will lead to Y% improvement in family planning. However, when you look at retrospective data, you do see the association, and Niranjan showed that improved education does have huge returns on neonatal mortality, nutrition, and family planning. So clearly, health sector has to work in tandem with the education sector and really ensure not only that girls and boys stay in school, but we actually have strong programs. Just like we have geography and civics, why not geography of the body and anatomy and civics of gender relations? So I think we do really need to improve what we are giving young people in schools, however we want to call it, but it should really improve bodily knowledge and autonomy, and understanding of ethics, rights, consent, coercion, all of those things that we talk about later, but it should be integral. And it actually is not only about SRHR, it is about relationships, intimacy, pleasure, power, everything that happens later in life. So I think that's really important. I do think that there is more that can be done in the workplace, albeit I acknowledge that women in the formal sector is low participation, but I think we have to make the formal sector more attractive for women, and we have to have more gender sensitive workplace policies, including looking at how many organizations, even within the health system, have POSH, respect basic breastfeeding spaces for women, creches, just like, a good audit of what is happening in the workplace for women to make work enabling for young girls and for young women. I think that's really important. And the private sector, therefore, has a very strong role to play, because we are hoping that more and more women will be working in the formal private sector and even semi-formal. I think there are ways in which civil society, SEVA has demonstrated a lot of this. There are other organizations, Anandi, Pradhan, and others, and I think there's a lot to learn from what they've done. I think that I do think that training teachers and service providers on what this means. What does adolescent sexual reproductive health mean, and how do we really enable it is very important. And it can't just be creating an adolescent friendly health
Thank you. That's
I know
very
my time is up,
important.
but I think there's a lot that can be done in terms of what already exists in policy, but really revitalizing and reimagining that and implementing it well. Thanks.
But I'm very glad you raised the issue of comprehensive education for young people on population, reproductive health, sexual empowerment issues, and working with the teachers, which is exactly what we've just begun to do in a program called Educately. Teachers themselves want support, and so these are very important and rich ideas we've received from all the panelists, great insight and perspectives. And I'm sorry, Sangamitra, we've eaten into with these brilliant thoughts into some of the time for the questions from the audience to the panelists. So I'll hand over to Dr. Sangamitra Singh, Lead Policy and Programs at Population Foundation of India, to take the questions from the participants and go forward with this. Thank you, everybody.
Thank you. And this was a wonderful discussion. We've received some very interesting questions from our audience. Some of them have already been answered in due course. So I'm going to restrict myself to just about 3 questions. I'll actually start with Priya because there was a related question around the need for school-based awareness on SRH. What are some of the barriers, according to you, that facilitators are facing? Can you talk about some of the challenges? And often we talk about adolescents in school, but out of school adolescents often get left out during this discussion and debate. So how do we reach out of school adolescents with the adequate information that they need?
I think, this has been a topic and so much work has been done. And unfortunately, it still remains a question, right? So not enough has been done. Honestly, there are a lot of interesting pilots. I think the problem is that we haven't been able to take them to scale. The RKSK program actually does focus on out of school adolescents. I think what we really need to do, and again, there are evaluations that have been done, really see how do we make that program more like the content of the program, little more cutting edge, the delivery more cutting edge. So I think the structures and the platforms exist. There are peer support groups, there are facilitators. The government program actually has provisions for a lot, even if it's, not optimal, but they still exist. I think the question is, maybe this is where more partnerships between civil society and government to help implement RKSK better, to really say what are the high impact practices that we can isolate and really focus on those rather than trying to do everything in every district and every block. I think Niranjan and Pop Council is, they had an atlas of SRHR indicators across the country. Why don't we focus on some indicators in some particular areas more in certain districts and only implement those? Focus on in-school, out-school for needs. In some areas, it could be drug use. In another areas, it could be mental health and suicide prevention. So I think we need to get more specific and granular. The platforms do exist. I'm sorry, I don't have a better answer, but I think it just needs more focus, more precision, and in implementation at a level where we can actually create fit for purpose kind of programs.
Absolutely, absolutely. We need context specific and audience specific targeted strategies. Thank you, Priya. I'd now like to come to Andrea. Andrea, there's a question specific to you, and one of our audience members has asked that in a country like India, how do you overcome strong cultural and social taboos, especially given that the rural area contributes about 70% of where the Indian population lives, And as an extension to that, there's another question which I'd like to add to this. What role do you see community influencers and local influencers really playing? And how can they really lead by example?
Okay, thanks very much. Clearly, not being an Indian and the only one here, it's a little awkward for me to answer and pretend I have the answer. But in my 37 years of working in Africa mostly, I can tell you that rural people can be very influenced by the right leaders and influencers if they have a reason to. So just because it looks difficult, I don't think it's an excuse for us not to try. That's one. Rural people might be risk averse, they might be traditional, but they're not stupid. They will always go where their best interest is. And if they are convinced that their daughters' lives will be saved, that by investing in education, they're able to improve their family lot, they will do it. They will do it. But the conditions have to be made acceptable for them as well. It's not just they're going to change their minds, but the incentives have to be there as well. And that's why I say it's a multi-sectoral approach. And then I think the other question linked to influencers, and those usually are religious leaders and community leaders. UNFPA is doing a lot of work to support the Panchayat Raj, working through those local structures that also have a significant female presence, even if the female presence is somewhat influenced even by the men on that structure. We still have to start somewhere. I wanted to say also that another mega trend is urbanization. Whether we like it or not, it's happening. It's happening in India. It will happen. And really what we've seen is with the population, the biggest challenge going forward in 40, 50 years is going to be how to support the elderly who will be left behind, and the very marginal and the very poor who will be left behind. But urbanization is a trend, and actually people say urbanization is the best family planning you can find. You don't need to do a lot of convincing once people move to cities. So that would be my answer. I don't want to pretend that I see India changing overnight. I don't. But I think it has to start somewhere. And I think also we're in a new era with technology. Even many of the poorest of the poor have cell phones. They may not have smartphones, but they have cell phones, so they have access to recordings. They have access to recordings in their local languages. They have access to free calls and services. So that's a leapfrog technology or a leapfrog intervention that could take things forward in a way we never imagined possible in changing attitudes. Thank you.
Thank you. Thank you so much, Andrea. And my last question is to Niranjan. It's also related to what Andrea just mentioned, and one of our audience members asked this question about how exactly, or what are some of the strategies that India needs to focus on in the coming decades to address the needs for our aging population. We know that our demographic dividend is for a limited period, only about 3 decades. So how do you really change those, how do you really see those policy shifts happening? And what are some of the preparatory measures that the country can really take? Niranjan.
Well, I think, as Andrea said, I mean, the opportunities are immense with the population that we have. I think from a program and policy perspective, what needs to be done is to recognize the issues and take action accordingly from the perspective of how and what do we need to invest in addressing the challenges for adolescents and young people. What those investments look like, and should we go as a vertical program only from the health ministry, or should it be more convergent multi-sectoral initiative? I think in the initial remarks from Andrea, she mentioned on how this needs to be a multi-sectoral focus. And that is where the policy shift is also required. We we have done really a great job as a country in having this focused program on sexual and reproductive health. I think going forward, and as we saw from the evidence, the factors, how they are contributing, and those barriers that are affecting, which are more contextual and the distant factors than the more immediate and proximate factors to the sexual and reproductive health issues. So that thinking in program design and policy shift is needed. On the other hand, as the successes that we have made in the program needs to also be sustained, while we have seen that in case of other epidemic conditions and in case of other health issues, that we think we have made a success and then comes back again the challenge. And so the family planning program, or say the sexual reproductive health program, should not take any backseat and needs to continue to invest and continue to reinvent from the perspective of where those gaps are and how do we need to address those gaps. Without which, if we settle on what we have achieved, it's going to be much more challenging, because the evidence clearly points out that family planning program, for example, can never stop functioning. We saw that in case of Punjab, where modern contraceptive prevalence rate, for example, in Punjab in 2015-16 was over 65%, has reduced to 52% or 55%. So, and we saw that there was a good method distribution and wonderful everything, but has reversed the condition. It may have to do with the COVID and other crisis situations, and these situations continue to emerge. I think the program also need to really integrate how this crisis and climate issues are going to affect the SRH needs of population, and what do we need to do going forward. That's my bit of solutions. Yeah.
Thank you, Niranjan. There's one last question that I'm actually going to, it's a common question for any of the panelists here. And it's around the provider bias that adolescents face in the health system. And I see that a lot of our audience members have asked questions around why adolescents are also forced to use private services sometimes, or no services at all. It stems from the provider bias that they face, especially in the public health system. So what are, if you were to give one recommendation really to address this provider bias, what would that be? And this is an open question for all panelists, like one comment each before we close.
Yeah, maybe I could start given how I saw the Q&A questions on the chat box. And I was like, it's not so much about the failure of the public sector. On one end, we haven't really given enough emphasis for the health workers to talk openly, to include them in the conversations on sexual and reproductive health, and also providing the access to services. And the public sector per se do not actually deny the services to the adolescents and young people. However, the choice of the young people is for the private sector. And I don't say that it's the adolescents going to the private sector is a failure of public sector. It's more about how this growing population is having a choice, making a choice between the public and the private sector, and where do they need to receive those services. When I put this in the context, in terms of the numbers, there were 90 million were receiving contraceptive services from public sector in, let's say, 2012, and it has increased to 110 million. And in the private sector, it has increased substantially. And why is that happening? Is because there is a shift in that contraceptive method that is taking place in the country, There's more and more young people going for the reversible methods of contraception. What they would like to see is having access, easy access, and the choice from where they can receive the services. With the growth and with the economic growth and development, the private sector actually also going to play an important role. And for population size of us, like the 120, say, million women and girls and 1.4 billion people, I think one sector cannot essentially address all the sexual and reproductive health needs. And that way I would say, while provider bias exists for adolescent and young people, but the sectoral bias do not. And sectors are complementing each other in terms of providing services. Thank you.
Thank you, Niranjan. Priya, any last thoughts?
No, I think that, you know, we just need, we need to brand our primary healthcare services differently for young people. So I think the fact is, I don't think unmarried young people would imagine going to a public health sector. So if we're really serious about getting young people to use public health services, we have to say that services, sexual reproductive health services are available both for private and public sector. And honestly, we can't say that right now because I think several people on your chat also talked about POXO. So I think that there are complications here. There's no pat answer. It's an incremental progress, moving from rhetoric to actual implementation. And I think we have to just keep working at it little by little, you know, get more young people into the and you know, cervical cancer prevention is a good space where there is provision. That may be a good way to start engaging with young people in the primary healthcare, public primary healthcare services, because there is a vaccine and there is going to be systematic engagement. But more than that, I feel like right now, we just have to keep thinking about one menstrual health management. Whatever services are less complicated, more enabling, get more young people into the public sector over. And yeah.
Right. Thank you, Priya. Very well said. Andrea, your last thoughts on this?
Yeah, there's two very quick sentences. The first one is change the law, advocacy around the law. And the second is incentives for the service providers. If you incentivize them, they will provide. That's all.
All right. Thank you, Andrea. On that note, I'd like to thank our panelists for this excellent webinar, for the very, very thought-provoking discussion. And I hope that the audience learned from it just as much as we did. Thank you so much and have a good evening.